Baltimore. Um, Today, we're excited to have all the CP Solvers community joining us for this webinar, as well as my program here at Sinai Hospital. Um, I'm going to pass the mic out to Dr. Ravi, that is going to be the co-discussant for the case, so we can think, so that we can move forward. Dr. Ravi.
Hi, everybody. Good morning, good afternoon, good evening. I hope everybody's doing well. And I'm absolutely stoked to be on today, Tuesday. It's beautiful outside, actually, in Baltimore. It's like 70, 80 degrees. We've had early summer. And I'm also very delighted to be here discussing with Franco. It's been an absolute pleasure having him here in the program and get to nerd out with him discussing cases. And he'll come by and be like, oh, I have a really interesting case. I'm like, tell me, but no, we'll keep it for a morning report or a CPS presentation. So absolutely delighted to be here. And our case presenter today is Sausan, who is zooming in from Jordan. I'm going to ask her to mute her mic and tell us a little bit about herself.
Hi, everyone. I'm Sausan. I'm a final year medical student from Jordan. I'm interested in internal medicine and in pursuing my residency in the US. And of the things that I like to do outside medicine, I like to bake, like brownies, cinnamon rolls. And the things, like some of the things that bring me joy is to drink my morning coffee and watch a sitcom. Yeah, and that's it.
Brilliant. What kind of sitcoms do you like? Do you recommend any sitcom?
I just recently finished Seinfeld. It's nice. Yeah. I don't have any recommendation for now, but I think The Office is nice.
Both are great choices. So spectacular. All right. Shall we start with the first aliquot, and Deborah, the whiteboard, please.
Okay, should I start now?
Yes, please.
Okay, so you're in your clinic and you're seeing this 25-year-old male who presents with a 3-month history of right lower quadrant pain.
Franco, what do you think?
Okay, so that's actually a great start because first, the age of the patient, 25-year-old male, is going to be an important modifier. It's different to have abdominal pain that is localized in a younger patient than in an elderly person. I would be more interested to know a little bit about the history in the background, about what other modifiers are going to kind of tackle the center of gravity that at this point is the right lower quadrant pain. For abdominal pain, I always go to have an anatomical approach. So I'm going to be on the lookout for what are the organs located in the right lower quadrant as the first step. But then I will keep in mind about that the visceral innervation of the abdomen and the further innervation, then it's going to be kind of like something modifying the thing that, oh, this might be a reflected pain, not located in the right lower quadrant, but somewhere else in the abdomen. Then exposures are also going to be important modifiers here, as well as if the patient has any recent travel or if the patient has any kind of social history or even family history, even ancestry can taking account for these kind of patients, especially when they're lower, when they have the age group population is kind of like on the younger side. I remember seeing a cause of porphyria that was more related to, with the ancestry was being the only clue for that patient to overcome. And then further down in the aliquots, it will definitely be helpful to see if this is going to be stratified for an abdominal pain with a negative CT scan or with a positive CT scan that could narrow or differential as well. But I think that is a great start. And of course, abdominal pain is going to be important to tackle down, seeing an approach that is going to be either anatomical, functional, or with all the other modifiers. I don't know what do you think about that, Dr. Ravi?
Absolutely wonderful. You just mentioned a whole lot of things there, and I kind of would go, my approach kind of would be slow. So this patient's coming into the clinic, so I don't think it's something that's catastrophic needing the emergency room. So what's interesting this afternoon, I actually have to talk about how to think like an internist to our new MS3s that are coming in to our our regional campus. And one of the complaints will be abdominal pain. But of course, what I will use or usually deploy, what we use on VMR, is the Vipo-mnemonic, which was just, if I can recall, last week, we just used that mnemonic. But in this case, I kind of have to use something maybe that may be relevant to the clinic. So this patient's had it for a few months now, so to the point where it will be almost chronic. And it's not something that's causing the patient to be keeled over in severe pain, but the patient's there in the clinic and is having this annoying pain. And I'm kind of wondering what kind of differential could we just deploy right now. It could be something that could be anatomical, like you mentioned, which I think is very fruitful, but I'm not quite sure. I would want to get more data that would help us to define what exactly is the process that's happening. Other kind of differential, I guess, frameworks you could use, something could be organ system related, could be physiologic, that could also be helpful. But here again, I think it's going to be more organ related or anatomical related, but we'll get more data to see where exactly can we focus our attention to. So I'll swing it back to Solson for the next aliquot.
Okay, so this is a bulky aliquot. The pain initially occurred suddenly. It is progressively worsening in severity, and it was described as being intermittent and colicky. There were no associated symptoms such as fever, weight loss, or diarrhea, although he experienced multiple episodes necessitating ER visits. His initial ER visit, he was diagnosed with renal colic, and he passed the stone that was calcium oxalate. Subsequent visit, he had an appendectomy due to suspected appendicitis, revealing an inverted but non-inflamed appendix with an enlarged mesenteric lymph node. Despite surgery, he had recurrent and persistent abdominal pain that was affecting his life. With the subsequent ER visits, dismissing his symptoms as being either due to constipation or gas without further investigation. He had multiple and severe pain attacks. Like even a sip of water would exacerbate the pain. He denied any recent diarrhea until a week before presentation, when he experienced watery diarrhea that is increasing in frequency, and eventually 3 days prior to his presentation to our clinic, it became bloody with painful defecation. I'll stop here.
It's also an absolutely wonderful delivery of this aliquot and the presentation so far. So what's building here, what's unfolding here, is something that we've seen on VMR and actually happens across a lot of emergency rooms. I'm just sort of going to comment on this, Franco, before we get going. But I guess this young patient was conveniently diagnosed with appendicitis, and this has happened. There's been multiple case reports where diagnostic error has been made with a patient with right lower quadrant pain, and appendicitis was presumed to be the cause of this, and it leads to an appendectomy. However, it doesn't resolve the issue. So you have to be judicious in your approach and think more so outside the box, what else could be going on with the patient, rather than just narrow in on something like that is quite common. We do see it. If you do any surgical rotation, you'll see a number of appendicitis visiting the emergency room. But in this case, this, I guess, rushing to judgment and not properly going through the differentials, or maybe not even entertaining the pertinent data, or not even getting a proper history from the patient, led to a rapid assumption of appendicitis and this procedure. And along with it comes a boatload of complications which this patient could be exposed to. So unfortunate, but now the problem still has not been solved. So like Noah put in the chat, multiple emergency room visits is a red flag. So we do need to get to the bottom of this case. What do you think, Franco?
So yeah, I agree with everything, and I did find I picked some clues about it. I would be really interested to see the actual surgical report. So it's like when you have like an abdominal pain and that has been recurrent, and you even go to the OR, it's like playing poker. You ask the patient when you go to see the surgery, and you say, "Oh, I'm opening the chest, I'm opening the abdomen, so I'm gonna see there. I'm opening the kind of like the pair of cards that you see in poker." So you need to see what was the result of that. It was just the clinical result of the appendicitis, or what caused the appendicitis. Sometimes they send the pathology report there, and there might be some granulomas lingering around the appendix causing the appendicitis. It might be just the usual bacterial infection or fecally that can cause appendicitis. So I would be interested in knowing that. Then I saw that somebody put on the chat a wonderful pearl that is kind of like, oh, you have the oxalate crystal in the urine, you might think IBD, and that can also be important in this case because this patient has is a young male with recurring ED visits with abdominal pain that got a negative kind of like surgery that didn't solve the problem. It continued over time, and now he has a blunt time diarrheal episode, but also mentioned constipation there. So there's alternating pattern between constipation and diarrhea. And now it's bloody. So even that at some point the inflammatory markers were negative, now we're seeing that there might be some signs of inflammation in that etiology of this abdominal pain, with the diarrhea and the improvement with the blood, improvement with the defecation, prompting defecation as well. So I would think that at this point, we are dealing with something that is systemic, that is causing that this patient is having this recurring attack. And it's not only kind of like lingering around like a specific organ. I think it's more like going to be on the patchy appearance or like an intersection of the whole bowel. So I think IBD for now is top in my differential, but also because we do have these red flags. We can also think about some other weird case etiologies, like for example, intestinal lymphoma that can present like this, or if the patient comes from a high tuberculosis prevalent country, it might be tuberculosis, like intestinal tuberculosis as well. Sometimes I have even seen cases of parasitic infection that can mimic appendicitis and that can have these chronic intestinal problems. So right now, these kind of like this is happening in the background. Thinking about this case for me.
Yeah, Franco, you just mentioned this phenomena of pseudo appendicitis. So infections can mimic appendicitis. From step one, I remember system one thinking Yersinia was associated with this pseudo appendicitis, can mimic appendicitis, and then Campylobacter jejuni is the other organism which can also mimic appendicitis. So I just wonder about pseudo appendicitis in this case. And in the chat, I'm seeing a lot of infection possibly being floated as a cause of this, in addition to all the other wonderful thoughts that you had. I'll swing it back to Sosan for the next aliquot.
Okay, for like his bowel movements, usually he opens his bowels every 2 to 3, like once every 2 to 3 days per week. He denied any adenophagia, dysphagia, mouth ulcers, joint pain, eye redness, skin rashes. As for his past medical history, he mentioned that he was diagnosed with IBS 5 years ago, and he takes Buscopan for it. As for his family history, it was unremarkable, only for like cancer in first and second degree relatives. He only knows one of them being diagnosed with leukemia, but he doesn't know the diagnosis of the other cancers. He has no known allergies. As for his social history, he smokes 1 to 2 packs a day since the age of 16, and he works at a potassium salt factory. Yeah, and he has no recent travel history and no recent sick contacts or animal contacts. And I'll stop here.
Okay, I think the important modifier here would be that he does have a background of IBS that at this point might be IBS that have been lingering around and like might be labeled as IBS, but might be IBD at this point. Regarding the family history, cancer in first and second degree relative leukemia, that also I'm keeping in the background the probable differential for this for the intestinal lymphoma as well. The smoking history, he definitely has risk factors, although it's kind of like he only has been smoking for 9 years. It's kind of like not that much significant for any other etiologies for me. I don't know what to make about the salt factory. I think it would be just noise at this point, but I would be really surprised if that's kind of like something that is gonna be a big clue in this case. I think that. What do you think, Dr. Ravi?
Yeah, I think I don't know about the exposure. I think Yasmin highlighted that in the chat. You always have to entertain that. So things that you do have to think about, medication-related side effects, could that be impacting this patient's presentation? The other thing is the repeated non-resolving presentation of this complaint. So you're right. We have established that this issue is the bowel. There's a background of IBS. Could this be an IBS related issue with this bloody defecation that the patient has? So I'm worried about all the things that you had mentioned. I think we might gain some momentum with the examination, hopefully, and the examination can help us if there are any systemic signs, especially the vital signs, if there's any sign of potential decompensation, like if there's tachycardia, if there's hypotension, if there's a fever, it may actually indicate or help us to direct our attention to maybe an infectious inflammatory state. And then the exam itself of the abdomen, if there are any features or hallmarks of other systemic features like skin involvement, maybe there's an autoinflammatory component to this, if there's eye involvement as well, joint involvement, and so on. So with a young patient, you always have to wonder about, IBS could be associated with autoimmune conditions, if there's any musculoskeletal association. So we'll swing it back to Solsan for the physical exam.
Okay. Like the next aliquots are quite short. The case is very short. So I'm going to give you the physical exam and I'll ask you a couple of questions after that, if that's okay. So for his on physical examination, the patient was afebrile. He had normal vitals like the heart rate, blood pressure, and respiratory rate. Nothing else was remarkable, only the abdominal examination, which was there was right-sided tenderness, and perianal skin tags were also noted. And my next question is, let's say you're in a resource-limited facility, or like your patient cannot afford expensive investigations. What investigations would you order for this patient? Like, how would you approach this case?
Well, I think first for the physical exam is basically a pretty negative physical exam. What I would approach coming from the background of a low limited setting, I would definitely see if there is any fecal leukocytes. There is actually a cheap test to see if this is an inflammatory area with again the inflammation, the IVD in the background. The other thing that I forgot to mention is that he did had at some point mesenteric lymph nodes. So I think for this case, having focused that this is a bowel problem, but also having lymphadenopathy that might have been reactive to the appendicitis or might have been growing there, because we might be missing possible obscure diagnosis of a lymphoma or a malignancy, I will definitely push for, even if it's a low degree setting, a CAT scan would be really valuable in that setting, just because the probability of cancer would be a never misdiagnosis and would impact the morbidity and mortality of this patient. And then the stool studies that are the parasitic studies as well, a direct observation of a parasite is actually cheap to see. From the inflammatory perspective, I have inflammatory diarrhea. I would like to see if there's systemic inflammation as well. So ESR and CRP would be helpful. I don't think those are kind of like expensive tests either. Besides of that, the fact that he does still have the right-sided tenderness, but without peritoneal signs, and he did have the surgery in there, I would just circle back that I would like to see some imaging at this point for that case. What do you think, Doctor?
Absolutely wonderful. I think, yeah, usually what I remember from just reviewing MixApp, the IBS is usually, it used to be a diagnosis of exclusion, but now we have clinical criteria and we split up into two subsegments. So IBS with constipation or IBS with diarrhea. And you do for the workup, I think that's a really good question here. If you're resource limited, definitely getting CBC, getting inflammatory markers, CRP, SED rate will be helpful. And then testing, like you mentioned, for coexisting infections. Maybe an infection is causing an exacerbation of this presentation. So giardiasis, testing for celiac, and also getting a fecal calprotectin may be helpful to see, hey, has IBS morphed into something like IBD in this case? So this may be something to consider. Or could there be a coexisting condition like celiac disease in this patient? It wouldn't be a bad idea, I guess, in the clinic if this patient presented, putting them on a FODMAP diet and seeing if this resolved the issue. If that didn't, then further testing with all these things that we kind of mentioned would be plausible, I think, at this point. But any other thoughts before we swing it back to Sorsen?
No, I think I don't have any more thoughts.
Okay.
Okay, so I'll give you the labs now, and the next aliquot, I'll reveal the final diagnosis. So the comprehensive metabolic panel was normal. CBC was normal except for mild leukocytosis and slightly elevated ESR. Fecal occult blood test was negative. Infectious causes were ruled out. A stool sample for calprotectin was ordered, and it came back as high, but I don't have the numerical values. And that's for the labs.
So not a lot there, although the calprotectin is very high. But Franco, we're at 12:25. Actually, might not be a bad idea just to do some breakout rooms and then let people, I think it's a short case. There's only one aliquot before we get to the diagnosis. So let's have people mull over in a breakout room and see what they find. All right.
Sure, I think my primary presentation would be a young male with chronic intermittent abdominal pain who presents with chronic intermittent abdominal pain and elevated calprotectin levels. Yeah, maybe I would just say a young male with a prior medical history of IBS now presents with chronic intermittent abdominal pain associated with, at this point, I would say inflammatory diarrhea and elevated calprotectin level, fecal calprotectin levels. That would be my primary presentation.
Franco did a great addition to the CPS Solver's website, breaking down along with Jack how to formulate a problem representation. And in that, you had highlighted, I use that for teaching, who is the patient, what is the syndrome, and the tempo of the presentation. The syndrome, what I think may help us in pivoting to diagnosis also, and a couple of people mentioned this, the significance of this mesenteric lymph node. So this patient underwent appendectomy and on pathology found to have enlarged mesenteric lymph nodes. I would add that, and that it didn't resolve the situation. So that would be my contribution to your problem representation. The question I was asked by Yasmin was, what is the significance? Will these mesenteric lymph nodes help us to decipher a differential? What kind of comes to mind?
So you have like mesenteric lymph nodes and you have diarrhea. On top would be like a lymphoproliferative disorder, like intestinal lymphoma, but also chronic infections can be lingering and chronic inflammation, of course. So I think that's a modifier there that we need to at least anchor if this is gonna. I don't think at this point we most likely have ruled out all the fecal infections. Um, we are anchoring like a high probability of this being an inflammatory condition. I would just resume to see if the mesenteric lymph nodes are present on a imaging or if they resolve after getting a specific treatment for the inflammatory condition. To think about like the next step of this patient case. He will definitely need to see if there is a repeat lymph node, mesenteric lymph nodes. I think the resolution of them is more important. The resolution versus persistence of the lymph node despite adequate treatment, that would be a good way to see it, I think.
Yeah, absolutely. Do agree with that maybe this was part of this pseudoappendicitis complex that we kind of floated, or people had floated earlier, and Yersinia does cause the mesenteric adenitis as well, an enlargement of lymph nodes. But if we go through what's going to cause lymph node enlargement, so the colonic system has its own immune system. You have the mucosal associated lymphatic tissue, and it generally sits there and is able to launch an immune response to anything that may be occurring within the bowel that may be foreign to the bowel. So it is part of the lymphatic structure of the body. But like anything, it can go awry. So one thing that was mentioned, neoplastic causes, so lymphoma within the bowel wall could occur. Autoinflammatory states could also occur within the bowel wall. Could this be, you mentioned IBD, that I don't think the calprotectin will indicate. It can elevate with any sort of an inflammatory condition. So it really doesn't carry that much pre-test probability, although it can help us to build a narrative of maybe inflammatory bowel disease. You know what's interesting? TB comes to mind. Could TB, although the patient doesn't come with constitutional symptoms of a typical TB patient, and this patient is in Jordan, so we do kind of anchor on this. Any patient coming from abroad, we have to think of TB, but TB can occur in lymph nodes. And guess what? These lymph nodes do exist within the bowel wall in this malt tissue. So something to also consider. And then the vast array of neoplastic causes. So we thought of lymphoma, kind of early for colonic carcinomas. Could there be a gastrointestinal like carcinoid tumor? There may be various others that are kind of escaping me, and then this pseudoappendicitis phenomena with Yersinia that can happen. So those are a few things. At this point, I think imaging in this country, I think imaging would have been done, and that could shed some light on what is going on within the abdomen. And I think if Sosan, if you have, I know you said resource limited, is there imaging or is there just the diagnosis?
Oh, there is imaging.
Oh, okay. All right. If you may.
Okay. Abdominal CT was done, and it revealed segmental ileal thickening with mesenteric engorgement and enlarged lymph nodes. And a colonoscopy was done, which identified ileal stricture, dilated vessels, and red areas at the ileocecal valve with small ulcers, and a biopsy showing non-caseating granulomas supportive of Crohn's disease. So the final diagnosis was Crohn's disease based on the clinical, endoscopic, and histological findings.
Wow. So yeah, it was the morphing of this into IBD and Crohn's disease. What do you think, Franco?
Yeah, I think it was an excellent kind of like a presentation, an excellent case so far, to remember all these kind of like approaches. And the takeaway would be for me also like maybe we can ask for the pathologist to reread the appendicitis biopsy sample to see if there is also granulomas in there, to see if that the appendicitis was caused because of the mesenteric lymph nodes. There might be also a component of IBD there mimicking the appendicitis or causing the appendicitis at this point. And for the fecal calprotectin, I think it would be also more interesting to see as not as a diagnostic, but also to see a response of the treatment, like decreasing levels of calprotectin, or the other way around, rising levels of calprotectin despite adequate treatment can increase like a relapse of the IBD.
Yeah, I don't know the rate of, I guess, morphing of IBS to IBD, or how often do we have to think about it? But I guess with this unfortunately, this patient went through the whole motion of misdiagnosis and appendicitis and appendectomy being done, and then having non-resolution. But the rate of the progression of IBS to IBD, I would have to definitely look at. But I think the workup is also key, like we had mentioned, looking for maybe a parasitic infection, looking for also morphing of this to celiac disease or IBD in this case as well. The malignancy aspect, definitely. But again, like we mentioned, there was no constitutional associating symptoms, no weight loss and so on with this patient. So that was less likely, although with a highly inflammatory state like Crohn's disease, you would expect that inflammation-associated weight loss. So remarkable case, definitely something, if I do come across this, Sosan, it will be at the top of my list. So I appreciate you and thank you for educating us with this. Do you have any teaching points or any reflection from this case, something you learned?
Yes, and I'll share them now. The first one is the diagnostic delays in underserved areas. So this patient comes from underserved area with limited resources. So these kind of patients, they usually receive, they get delayed in diagnosis due to limited access to healthcare resources, including having specialists and the diagnostic tools. But this patient was lucky that during the surgery, when the lymph nodes were found, they took a biopsy and they sent it to pathology, but it took a while to come back. And when it came back, they told him that he should be referred and go and see a specialist. That's when he came to the central city, to Amman, to our hospital. And the second thing is the impact of initial IBS diagnosis, as I think that his initial IBS diagnosis added some complexity to the patient's case, leading to assumptions that his symptoms were solely related to his IBS, and he didn't get investigated more, especially with the overlapping symptoms that he had. And the third one is the atypical presentations, or patients that present with the complications of a disease rather than the classical presentation. So this, I want to highlight the importance of maintaining a broad differential diagnosis for chronic abdominal or chronic gastrointestinal symptoms, and to consider IBD even in the absence of typical classical findings. And yeah, thank you.
Excellent points there, Sosan. Absolutely stellar and a very important points there. So appreciate you educating us with this. We have a few minutes. I'm going to ask Ravi, what do you think, or was there something that maybe came across your mind that could have led us to diagnosis of Crohn's in this patient, if you're available? And he's muted.
Yeah, good morning. Hey, 1 second.
Good morning.
Hello, everyone. Let me show you something first. I don't know if you can see me.
Yeah, we see you.
I think he's muted.
You're muted. Ravi, you're muted.
Wow, Travis to the rescue, like a true ER doctor. I was saying hello from sunny California. That over there is the, I don't know if you guys see it, that's the Golden Gate Bridge. But even prettier is this guy. I really enjoyed this case. I think there were a lot of interesting things to reflect on. I think, Salsan, the way you told the story was really engaging. I think that it's very rare for a recurrent abdominal pain issue to be localized. And I think the moment that you said that, Salsan, I was very intrigued, because most recurrent abdominal pain diseases are often generalized. So you think about all the esoteric ones that we diagnose in CP solvers, and then the more practical ones we diagnose in real life: AIP, lead toxicity, constipation, so on and so forth. They're almost always generalized. So the moment that you presented a recurrent abdominal pain that's localized is the moment it became very intriguing. And I think that you can ask yourself, what kinds of recurrent abdominal pains localize? And often the answer lies in either the right upper quadrant with biliary colic, or the flank with renal colic. But I was like, wow, episodic right lower quadrant pain. And that made us really think about the possibility of recurrent IBD flares in the ileum in particular. So I think that was really intriguing. But I think that this case goes to show how difficult it is to diagnose chronic intestinal issues. And I think that based on a recent study, the early use of a procalcitonin can be very helpful because it has tremendous discriminatory power between IBS and IBD. And procalcitonin that is elevated is really a red flag against the diagnosis of IBS. And the way I'm formulating this case is less so about IBS progressing to IBD. I think it was much more so that IBS camouflaging IBD. I think Sausan also illustrated the other value even before the procalcitonin, which is the value of the rectal exam and the anal exam. And here, in a patient who lacks constipation, the presence of anal tags and maybe even anal fissures is virtually diagnostic of IBD. So that was really cool. And the other pearl I will share is on a CT scan, as you both pointed out. By the way, as a tangent, Franco, I was going to text you privately, but since I'm here, I'll just say it's been unreal to listen to your reasoning 3 years after I last listened to it. The growth is unbelievable. It's cool that it's caught on tape. It's really poetic. I saw something in the chat. Yes, I meant calprotectin. I'm sorry. I don't know what I said, but yes, it's calprotectin. But finally, I'll share that like when you're looking at the CT scan, segmental findings can be very suggestive of Crohn's. Here we heard segmental ileitis without pancolitis. But I've learned from our astute radiologist that just like Ravi pointed out, the extraintestinal manifestations can be a clue to Crohn's. There are radiographic manifestations extraintestinally that can really suggest it. So if on the same CT scan, you see evidence of a sacroileitis, you see evidence of PSC, primary sclerosing cholangitis, or if you see stones in the kidneys that are suggestive of calcium oxalate stones, that can really help you select inflammatory bowel disease from the many conditions that cause bowel wall thickening. So ultimately, you're seeing that there are tools on exam, the rectal exam, there are tools in laboratory assessment, the calprotectin, and there are subtle imaging clues, namely the finding of radiographic extraintestinal manifestations in the gallbladder, in the bones, and in the kidneys that can really help make progress in areas where you might not have resources to get a colonoscopy and a fancy biopsy. And I think this case is a great example of how much progress you can make by using recurrent acute plus localized, by using the calprotectin and by using the imaging. It was really, really cool. I don't know if I answered your question because I was in a running induced bliss. So let me know if there's anything else I missed.
Oh, no, I just wanted to see if you had any input on this and any teaching that you can give everybody. So, but there was definitely a lot of teaching there, especially on the imaging and also acknowledging how difficult it is, a difficult case. And I think definitely will help us if we do come across this presentation. Any reflections, Franco, before we go to teaching points?
It's always great to see these cases, how to unravel. I know that in this setting might be it's different from when we see this patient like in how it could base, but in reality, this back and forth of uncertainty is what is kind of like always amazing how we can overcome the uncertainty with good clinical reasoning. And I think that is the big reflection I have, that clinical reasoning is always going to be our tools to like defeat uncertainty.
Awesome, thanks. Yeah, and I also want to echo what Ravi said. Is just watching you and your growth and how much you've gained out of CP Solvers is amazing, and that's just a testament to what you can achieve by doing these case discussions. And also, it fuels your quest for knowledge and your interest in medicine. So, I really appreciate you coming on and showing your skills today. And we'll take it away with teaching points by the fabulous Parisa.
Hello, everyone. Thank you so much, Susan, for bringing this amazing case. And thank you, Dr. Ravi and Franco, for amazing discussion. For the teaching point today, we had a young patient who had the history of IBS and appendectomy, and he had a chronic presentation of abdominal pain. We have a famous mnemonic in the clinical problem solvers. We usually going through VPO, which is vascular, ischemic, and perforation and obstruction reason. when we are having abdominal pain, we need to think about it as a localized or referral pain or generalized pain. We need to get a detailed history to develop a diagnostic framework. We need to ask about exposure, family history, patient age, and tempo of the presentation. Our approach could be anatomical versus functional, and we also need to think about negative CT scan versus positive CT scan. We also learned that multiple emergency visits usually are the red flag, and right lower quadrant pain could be diagnostic error for the appendicitis. We also learned about pseudoappendicitis could happen in the context of Yersinia and Campylobacter jejuni. We learned that tachycardia, fever, and hypotension usually guided us through infectious reason, while skin involvement, eye, joint involvement, and musculoskeletal involvement usually guided us through autoimmune reason for the presentation. We also, in this patient, we have mesenteric lymphadenopathy. That could be, we learned that it could be the reactive to appendicitis. It could be also lymphoma within the bubble wall. It could have chronic inflammation reason like Yersinia, which is famous for having mesenteric adenitis. It could be IBD. It could be TB, which is also accompanied with constitutional syndrome. It could be carcinoid tumors and colonic cancer. In that case, these could be accompanied with weight loss. We also learned about IBS, which is usually diagnostic of exclusion. We learned that IBS has different type. It could be IBS-D, which is diarrhea and abdominal discomfort. It could be IBS-C, which has constipation dominant, and it could be mixed type of both. The things could helping us in distinguishing between IBS and IBD are the tests. We could get CBC, we could check inflammatory markers. We need to consider coexisting infection like giardiasis. We need to rule out celiac. And the other thing which is really helpful is fecal calprotectin, which is elevated in IBD. And the other thing which is helping us is the imaging, specifically finding of renal stones and biliary stricture. It is more likely to be IBD. We also learned that we need to go through the pathology read of the appendicitis in case of finding any granuloma formation or other kind of clinical findings. And also we learned that anal tag and fissure, anal fissure are more common in the IBD versus IBS. It is all I have. Thank you for this amazing case.
Amazing job, Parisa. It's almost like a lecture on this VMR. So thanks again. Appreciate your teaching points. All right, everybody, have a great rest of your Tuesday. Bye. Bye, Franco.
Bye, everybody. Bye-bye.